I've been doing a lot of mentoring of medical students this week, and so I feel like I'm teaching. So here's the question. Who here has advanced directives tucked in, finished, you're comfortable with your documents going forward? Okay. Yeah. Are they finished and filled out? Are they completed? Okay. A lot of my patients, they come back year after year and say, yeah, I've got the copy from 3 years ago and the one from 2 years ago and last year stacked up on top, and we haven't done them yet. So I had options of what to talk about, what to converse with everyone about tonight. So please make it casual. There's not a single thing about me that's proper. So if you have a question, raise your hand, stand up, say, hey, I don't get it. This is what I need. We could either talk about advanced directives, the power of attorney for healthcare piece, why they are important, or we could talk about how I decide if you want me to start my heart again or not once it stops. The full code DNR question. Or we could do a little bit of each. Ooh, choice C. When all else fails, you pick C. Okay, so here's the dealio. Let's go backwards a little bit. And this might lead into the do I want to start my heart or don't I conversation. In the world, in the United States, we're trying really hard to encourage all of us to be able to say, at some point in my lifespan, I'm going to, here it is, die. I know, I said the word. Nobody wants to say that word. We pass away, we pass on. But we're all going to die, and that's part of life. And what we are hoping is going to be part of the new generations is that it's not the old-fashioned way, that when I start to get sick, I panic, I go into the hospital, and everybody does stuff to me that I don't know if I want or if it's going to even help me live better. And so oftentimes people have said, you know what, I don't think I want that, or maybe I do want how I don't know what I want. I don't know that. I have choices. And so what's happened nationwide, they are pushing the medical community to say, person in front of me, here is where your health is now in 2021. This is what I think it's going to look like in the next year, 5 years, 10 years. How do you want to live those years? What do you want it to look like for you? Your path might be very different from your path. And so as we have ability to put our finances this way and we can live here and we can travel here, we also can choose what's important to me going forward and how I want to live. And subsequently, when that time comes, how I want my death to look. And it sounds kind of weird. A lot of my patients say, well, you're the doctor. I'm not the medical person. How am I supposed to know what I want? And so in order to start this conversation, we realize that at some point, most of us are not going to have the luxury of a crystal ball saying you've got 13.2 years before you can't make your own decisions. We have to plan ahead, assuming that something someday might happen to me so that I need help making those medical decisions. And we call that a power of attorney for healthcare. We all on the same page? Okay. What it is, and I encourage all of my people in the clinic, 18 years and older adults, to be thinking about it, because I could walk out here and somebody could come zooming around the corner and schmuck me. I don't think I want to die yet. I don't anticipate that I have a lot of health concerns that will get me tomorrow, but that's why young people need to think about it, as well as my 102-year-old that I saw in the clinic this week with this many medical conditions. And so the idea is that while we are still making our own choices, our own decisions, I can name a family member, a friend, a neighbor. That'd be about all I'd want. To be my voice, to put my wishes out to my medical team when I can't do it. And it's so very simple. It's a document. You say, yep, this is my name, my address. I like this person and then this second person, and this third person, because they know me. I have talked with them. They know what's important to me as I take this journey, and then I get witnesses to sign it, and that's all you have to do. That now becomes a legal document. There are 4 checkbox questions, yes or no. And they say that I am giving these people the right to make decisions if I want rehab in a nursing home or an assisted living. They can make decisions about feeding tubes, and they can make a decision if I'm pregnant. And that's all. This document, then, some people have feared as soon as I sign it, I don't have any rights anymore. That means that my husband, my kid, my friend are deciding for me. And that's not the case. It only becomes active in Wisconsin when 2 doctors, a doctor, psychologist, and or now we can do a nurse practitioner or a PA. PA? Okay. Actually look at me, examine me, and sign a second document saying that I can't do it for myself anymore. Then person 1 is my voice. I call these insurance papers for our health. We would never dream of driving a vehicle, having a home without insurance. But by golly, when we need it, we are so glad we can pull it out and say, I have it. It does nothing until we need it. That's part number 1. Some of our surrounding states have default people set up for us. So let's say I live in Illinois, and something happens to me today and I don't have these papers, because why do I need those? They automatically would legally go to my spouse, and that person would then take care of me until I can again. In Wisconsin, we don't have that, and I'm going through a case right now with one of my patients. It's just heartbreaking because they never felt the need to do these. And now she's got cancer, it's in her brain, and she cannot make a decision, much less, she can't decide what to eat for breakfast, much less where to go with her health care. And so what we're now starting is a guardianship process through the court system. And her son is over there going, tick, 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 tick. We're like, son, sorry, we can hear you, but you have no right to make decisions on your mom's behalf because you're in the state of Wisconsin and your mom never gave you that privilege. So one of my big reasons that I think these are so important is because I'm a control freak, and I don't want some nice person appointed by the court making decisions about me when I'm case number 1632B and they have no idea what's important to me. So the first part is to get these established. And the hard part then is part 2. And part 2 is started today, and it goes all through our lifetime. And part 2 is taking time to talk to those people, 1, 2, and 3, talk to our family and friends and say, okay, guys, let's have a little cup of coffee. Let's have a conversation. When I get to the point where, and this is where it's all up to you, where I can't feed myself, where I can't walk, where I can't speak English meaningfully. This is what I want you to tell the medical team to do for me. And it can be everything from, I love technology and gadgets, so plug me in and keep me warm for the next 500 years. I want to be the weirdo from the years 2000. I want to just be warm. Just do it all. And other people say, no thanks. And I hear so many times from my patients, if there's no hope for meaningful recovery, if I can't get up and walk, and if I can't live, I don't want to be kept alive just because. And so there's a spectrum everywhere in between. And so the idea is to figure out maybe what living means to me, rather than, well, if I can't, then I don't want this, and I don't want that, and I don't want this. I don't want breathing tubes. I don't want feeding tubes. Maybe turn it around. And I stole this from one of my patients, so I'm not that brilliant. She said, turn it around and say to my family, this is what meaningful life. This is what life means to me. And she was a word lady, and she wrote in her beautiful handwriting on a legal pad piece of paper how much she enjoyed her coffee in the warm windows and snuggling with her pets and feeling the little arms of her great-grandkids come up and give her hugs. And she wrote all of this and what life meant to her. And at the very end, she said, "To my family and my decision makers, if I have a health concern that requires decisions, I want you to ask the doctors and the care team if that test, that treatment, that surgery, that pill is going to 100% guarantee living as I have printed. Then, of course, please say yes, do it. But if they can't guarantee 100% that their thing is going to allow me to live, please be brave and say, no, thank you. It's time for me to die." And it was a very chilling thing to read because most of us think, don't. And she said, this is life. And she basically gave her decision makers permission to say, no, thank you. And it was kind of an interesting way of looking at this project. And so the idea is Thanksgiving is coming up. Instead of everybody sitting around the table and going, "See, Dad over there, he's looking really bad this year. He's losing it. What's going on with him? What are we going to do?" It should be, "Hey, Dad, guess what? You're looking a little rough this year. Let's talk about what happens if. What happens if you get pneumonia this year? What happens if you have a stroke? How can we guide your medical team to help you? Do you want to go to the hospital or don't you?" And so the idea is today, I might be perfect. Next week after I get COVID and pneumonia and I've been in the hospital forever, I might not look so good. I maybe can't walk on my own. Maybe I have to have a breathing tube. My ideas change as to how much I want for health care based on where I am now. And these documents don't have to have anything written because the idea is that your decision makers are walking this road with you. So that next Thanksgiving you might go, "Hey, Grandma, you're looking pretty good. If your heart stopped, what do you want?" "Oh, I've got Christmas cookies to make, so start everything. Do everything you can." But then Grandma might fall and break her hip and have a brain bleed. And now Grandma says, "I can't do cookies in a nursing home. I don't want somebody wiping my bottom. If something happens, if I get an infection, don't treat it. Let me die peacefully." And so these are ongoing conversations that change based off of what my health is doing, what I see my family down the road, my neighbors going through. There's nothing that's set in stone. And so then leading to the question of, when do I start my heart, when don't I? What can I decide about? The easy question, I think it's the easy question, is DNR full code. You've heard the terms? Yeah, okay. DNR basically means in the very moment that my heart stops, I fall over, the old-fashioned, Annie, are you okay? Wake up, are you there? No heart rate, no breathing, no response. That's the only time that a DNR wish comes true. I will not attempt to do chest compressions, breathe for you, electricity your heart to start it. DNR, many people fear that when they say don't resuscitate, means that if I get a little pneumonia, I can't catch my breath, I have to go to the hospital. They're going to look at my arm and say, she's DNR. Yeah, doesn't matter. Deal with it. Go sit on the street corner. Good luck. Doesn't mean that at all. People fear that if they have DNR in their medical charts, they're put in the back of the nursing home and nobody looks at them. Nobody cares for them. But the time that DNR kicks in is when my heart already stops. And so the idea is that all this time before that, we can guide how much medical treatment we take versus how much symptom management treatment we accept. And so let's use the example of memory loss, dementia, Alzheimer's disease, any of those things where my mind is failing faster than my body oftentimes. This is what I see in the nursing homes, assisted living so often. It's heartbreaking for the family because that generation didn't always talk about what was important to them. And so oftentimes with the memory disorders, my body is great. It's my mind that doesn't keep my body going. And so let's say I'm living in a nursing home and, I'm kind of happy. I don't know who you are. You're a nice guy. Thanks for visiting. And I can still kind of totter around in my wheelchair. I can kind of feed myself and life's okay. And then I get a little goofy and the doctor says, you've got a bladder infection. Let's do a round of antibiotics. And the family goes, yeah, that makes sense. Take the pills, we go better. We're toddling around, life is good, and then pretty soon we're looking about 5-6 months down the road, and all of a sudden I fall, I break my hip, and now I'm bleeding. And so now I'm in the hospital. I have to have surgery, I get blood transfusions, and I go back to the nursing home and I can't move my wheelchair. Now somebody's got to feed me, somebody has to pick me up and get me in and out of bed. And I kind of recover, but boy, Grandma just isn't as energetic anymore. And so all of a sudden we do blood work and there's bleeding someplace. Do we do a transfusion? Transfusion seems simple. It's a little IV, put some fluid in, things get better, but it's a little confusing because now you're poking me with needles. It's a lot of fluid. I can't do it in my home of a nursing home. And family goes, yeah, let's give it a try. Maybe we can get some of that energy back. Makes sense. Well, it works okay, kind of. Grandma's back sitting up better. She's got pink cheeks, but pretty soon we're a month later, here's a bladder infection. Do you want to treat with antibiotics? Well, it worked last time. But now her stomach is so upset from the antibiotics that she can't eat. And now we're thinking, do we go to the hospital for fluid? Seems simple. Well, now we're in the hospital again, and I'm getting just crazy because you guys just keep moving me here and there, and there's strange people all over, and those people up there are talking to me, and I don't know why, and I want to get up and leave, and I fall again. And now I break my other hip. And so now we decide, do we do another surgery? And the family stops and says, why are we doing this? In this year, have we ever seen Grandma who just kind of teeters along and is happy, enjoying the sun and the environment? We've never seen Grandma like that again. And so the family stops and says, maybe it's time to say no thank you. And so the family can say, no, I don't want that other hip fracture repaired. They can say, you know what, this is the third infection this year. It hasn't brought Grandma gloriously back. I don't want antibiotics. I don't want IV fluids. I don't want more transfusions. We can say, let's move to comfort. And that's the old-fashioned way of looking at Grandma in front of you. Grandma's kind of restless. She's moving. Maybe she has pain. Let's give her some pain medicine. Maybe she's warm. Let's give her cooling blankets. Let's treat Grandma in front of me instead of, let's order x-rays, let's send her to the hospital, let's order more tests. And we have the choices to make all of those decisions. Let's use an example of a cancer patient. A lot of times they have low hemoglobins and they're constantly going in for transfusions. And so maybe you get some transfusions in January and you're great until August. But the cancer gets worse, and we're having this conversation, do we do a transfusion in November? Yeah, it's Christmas, but it didn't work, and now we're asking for transfusions in December and January. It's not giving that person a curative treatment. What is it doing? And that's a question only we ourselves can answer. Some people say that's just prolonging the inevitable death rather than treating a disease. I get my transfusion, I'm good for the next 50 years. And so those are kind of the harder questions, that I encourage my families to be thinking about. Do you want antibiotics 2, 3, 4, 5 times a year for the same infection? If my memory is so bad that I don't remember what to do with this glass of water here, and even if somebody puts a straw to my lips, do I know what to do with it? Is it the right thing for me to put IV fluids in my body? And those are the hard questions. But if you turn it around from the family perspective, if you've thought about it and talked about it and said, yeah, a little bit's good, this is not so good, when that time comes, those family members will take a sigh, maybe 2 or 3, say, you know what, guys, this is that time that Grandpa had always talked about. This is the time now to say, we're done with a medical model. Let's move to comfort. Let's let Grandpa be peaceful. And I don't know how many of you have walked that journey of dying with friends or family, but there is such a difference between, oh my gosh, I can't starve Dad. I can't make the decision to starve him. I cannot do this. He's going to be hungry. I can't do that. I just don't know what to do. Versus, Dad never wanted this. We're going to sit next to him. We're going to hold his hand. He's going to be at home. We're going to be in his apartment. He's not going to be in the hospital with nurses and IVs and beeping machines. We're going to sit and laugh with Dad about his first popsicle that he put red popsicle juice on Grandma's white carpet and he got in trouble about it. We're going to honor Dad's wishes and say, enough of the medical world. Go ahead, Dad. It's okay to die. And it does happen. So I'm done. I like those stories. I've had some really fun, I think they're fun. They're heartwarming journeys with families that truly the kids came, everybody's laughing. The individual who is dying is surrounded. The last thing that they hear is laughter and stories. And the people who have studied end of life and hospice, they teach us that touch and hearing are the last senses to go. And one of the things that a lot of people hold on to is, will my family be okay without me? Who is going to take care of the people that I've loved for 40, 80, 100 years? And if they can hear the stories about, well, got to get groceries tonight, we've got Halloween coming, what kind of candy are we buying, what are we going to do for the holidays? They can sense that life goes on and things will be okay without them. And oftentimes that's that final let go that they're waiting for. So nobody's snoring yet. What other questions, what other things do you guys want to know about?
How specific should we be in the different areas of care, or general in different areas of care?
That question, how specific or general are you with your guidance? That's kind of why we don't depend a lot on the living wills. The living will used to be this beautiful written out, do this, don't do this, how about this, don't do this. In the medical world now, we use that more of a guidance. When somebody was able to do this, they wanted to survive at all costs, versus we don't want any of it. But the problem is that we have no clue what technology is going to give us next year, 50 years from now. And so if you write in there, and I laugh every time I read, well, I'll be on you can attempt CPR for 15 minutes, or I'll be on a breathing machine for a month. And after that, you can let me go. Because it's so hard, depending on what the illness, what the injury is, we have no idea. And so a lot of times those agents that you've named are hoping to know you. They are in constant contact with your medical team. You know, some people, I had a lady, bam, she had a stroke. To the medical team, it was pretty clear that this was not going to be something she could recover from. And so we started with the family. This is not looking good. We could wait, this and this and this is going to happen, or we can let you go home with her and be with her. Other times you see, oh, this looks really bad, but this and this is looking hopeful for some kind of a recovery. How much do you want to give us for time? You know, sometimes we'll put in a feeding tube expecting that a stroke recovery will let that person eat in a month, 6 weeks. Some people will do the aggressive, yeah, I'm going to keep going, but then you're in the nursing home for 3 months and this complication and this complication. And that's kind of their own grieving time to see this person's not coming back. But then hopefully you've given them permission to say, if this isn't me coming out, then start backing away. And so that's how those conversations are kind of meant to be used. If that helps any. There is no black and white. And that's why you have the conversation this Thanksgiving and next Christmas, because it changes. It changes. Anybody else have questions?
Yes. If you've got a living will or whatever, does that have to be changed every so often?
Changed, not necessarily. What the recommendation is, and what I try to do when you come in for your once-a-year physical, pull that document out and look at it again. They suggest that like with our financial portfolios, whatever those fancy things are. Take a look at it. Make sure that you're at the same address, that your agents, your voices are still alive, are still able to think and verbalize what's important to you. Many people, they put their spouse, and their spouse died 3 years ago, and now we have nobody else on the list. And so with big health changes, pull them out and look at them. If everything is current and your people are still there, the phone numbers are accurate, you don't need to change them. But just make sure that it's not some antiquated document that's not useful.
But you do have to have one, at least, that is in charge, right?
I always encourage people to go 1, 2, 3. If it's 4 and 5, that's fine. It makes me cringe when it's 1, 2, 3, 4, 5, because then we need 5 people at the table, 5 people in agreement. And if one person is climbing mountains in China and we can't get a hold of them, these 4 people can't really do their job. And so a lot of times the reality is, if you have that many children, neighbors, whoever you trust, the people will be there, and the conversation is had with everybody. And it's really only a 1, 2, 3 if there's a really difficult, these guys want this, these want this, that number 1 really gets that loudest voice. But everybody's at the table practically. I always ask for 2, minimum of 2. It doesn't have to be your family members. Sometimes I had one person speaking and she said, you know what, I'd love to name my husband, but he loves me so much there is no way he's going to listen to me. This document becomes his thing, and I don't trust him to do my thing when I need him. So out he went, and there went her best friend as number 1. And so that's something to think about. A person is not meant to be their own thinker. They are to be my voice. It's a responsibility.
You've got it all written down. They are supposed to go by that.
Yep. Key phrase, supposed to. You're smirking over there.
That's right, they are supposed to.
They are. Yeah.
So would you write down, I would assume, don't they have to? If you have it written down in the hospital, no, they don't have to? They can make a different decision than what you wrote on that document?
Yes,
Oh.
healthcare agent has the legal authority, so yes. So you have to pick somebody who understands and supports your healthcare philosophy and your decisions. Just like she said about the husband. I always say, pick the person who can make the hard decision. because you're putting them in a position where they may need to make a hard decision.
Gives me more gray hair when the agent does not. I'm like, look, it's black and white. There's no question. It's not hemming and hawing and sort of. It's do or do not. And they're like, I don't care. This is what I want. Whew. It's icky. It's icky.
Can you add anything to it after the documents are signed, like what funeral home you would wanna be? Or does that all have to be?
That doesn't have to be in the power of attorney for healthcare. And so I would just put that in writing separately. So
These documents can change. And I always tell my patients, you know what, if you put all this work into it and you love it, and then all of a sudden, bam, something happens, and you're like, ugh, I don't like it. You pick that original one up, you rip it in half, you grab a new one and start it and redate it with your new wishes, your new agents. It's a moving document. Just remember who you give them to so that when you do make a new one, they aren't working off of the old one. So there is a suggestion that you just write a list. Who did I give these to? River Falls Hospital, St. Paul, Children's, wherever you give them.
Because I know my sister-in-law passed away, but they were not allowed in the hospital. They did not know what was going on. That's why I'm asking these questions.
One would.
And then they called and they said she passed away.
Oofda. One would hope that the care team at
There was 2 of them in charge
Okay.
with medical, but they wouldn't communicate.
Oofda. That would be time when I was sitting at the Thanksgiving table, and one is at the kids' table and the other's at the patio outside. Maybe I need to pull my documents out and make sure that they are what I need now. Oof. I'm sorry that happened. That's hard. You had a question?
Well, yeah, I was gonna ask about kind of timing then. When you're looking at like a DNR, DNI kind of order then. So you have an example where if that's not in place, or if it is in place, the timing of that where if I do it prematurely, for example, if I were maybe to have a DNR, DNI order right now and I get COVID, I'd kind of want to be intubated, I guess, at this point, because there's a good chance that maybe I would survive that.
Mm-hmm.
So do you wait, do you recommend that you basically have that conversation with your agents and then wait until that time comes before you give that order? So that your power of attorney for healthcare then has that decision based upon your conversation, okay, let's do the DNR now, versus doing it somewhat prematurely?
Part number 1, if I get COVID and I'm short of breath, my heart's still beating. And so nobody should be talking about DNR at that point.
Well, or DNI,
Well, that's a whole other conversation. Okay. You should have your machines and whatever to get you through the illness. There is an order where if you say, I don't care no matter what, today at 30, next year at 130, I never, ever, ever, ever want somebody to restart my heart. There's a way through the state that you can register that with your doctor's order, and you can get a bracelet, and that will protect you from no matter what, today, next year, from somebody starting your heart. But some people say, I'm young, I don't know what might be coming. I expect if my heart stops, I could have a little surgery and I could walk out. Then your agent should be able to say, this is a time to try and fully treat me versus, this is not looking good. Don't continue. And so if you have trust in your agent, you guys are like this and constantly communicating, it'd be fine to wait until that one thing happens. My lung cancer is through me. I've had a whole, then you could do the formal DNR. That help?
Yep.
Okay. Any other easy questions? Yeah.
So, if you give it to your doctors at your, your hospital clinics,
Yeah.
whatever, that you normally go to, what do you also make sure that the person, the agents, whatever, has copies of them too? Because what if you're in Florida,
Yep.
and something happens,
Yep. What
and
I tell
that hospital doesn't have a copy?
Of course. What I tell my patients is once you have this document done, you keep your original wherever you keep your stuff, but then make a list and make 9 million copies and give them to your agents, your hospitals, your clinics, your specialists, but give them to anybody else who might be around you. Give them to your kids, your grandkids, your nieces, your nephews. Just because, and when the individual is older and fragiler, and once it gets activated, meaning you are now my voice, then I encourage you to make copies of that activation paper. Keep it in every vehicle that you drive and every purse that you might have, just because it's like when you're pregnant and the kid comes, you aren't going to go, oh, should I take that paper, shouldn't I? You're just going to go to be with that loved one, and they'll say, where's the document? So you can make as many copies as you want, just as long as you remember where they go. That was easy.
Yeah.
Thank you. Yeah.
The power of attorney healthcare versus a living will, are they separate, integrated, or two separate things?
Two separate documents.
Okay.
The POA, power of attorney for healthcare, names those voices who will be your spokespeople, and that's pretty much all it is. It's giving them permission for those 4 questions. The living will is that beautiful, hopefully now conversation, but it's more of your guidance of what's important to you. Yeah. Yes, I get to turn it over. Thank you guys for not snoring and terribly falling asleep. And please, 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 at all costs, for those of you who may or may not have these tucked in yet, and I didn't pick you to, please do them. And now Medicare does pay for a visit with your provider, your doctor, your nurse practitioner, whatever, with the usual 80-20. So if you say, oh my gosh, I went to this thing and it was dark in River Falls and I don't know what they're talking about and I'm supposed to be, what do I do, Dr. Jones? Medicare will cover that as a covered service as many times as you need to do that with the person that knows you and that you feel comfortable with. Because hopefully, if something will be happening, it will be your medical team walking that journey with you. And so they can help make sense of it, make sure they know what's important to you.